Hey everyone, and welcome to The Explainer. Today, we're basically turning this into a giant whiteboard session to map out some incredibly complex, but honestly fascinating clinical pathways in pediatric care. We're going to focus our lens entirely on pediatric bone infections, and then we'll dive into the evolving realities of limb loss and amputation in kids. Okay, let's dive into this. Here is our agenda for the day. We'll cover the infection pathway, diagnostics, causes of pediatric amputation, the massive differences between emergency and planned surgeries, phantom pain, and finally, prosthetics and long-term support.
All right, Section 1, Pathways of Infection. Let's look at exactly how bacteria manage to invade pediatric bone tissue in the first place.
So bacteria, usually Staphylococcus aureus by the way, basically have two distinct routes to break into the bone. On one hand, we've got contiguous spread. This is when bacteria travel directly into the bone from an adjacent open wound or fracture. This is exactly why an open fracture is a massive red flag and why doctors use prophylactic antibiotics so aggressively. On the flip side, we have hematogenous spread. In this scenario, the bacteria are hitching a ride through the child's bloodstream from an infection located completely somewhere else in the body, eventually setting up camp remotely in the bone tissue.
Now, you might be wondering, what does this actually look like in a patient? Well, a simple bone fracture hurts because of the physical trauma, right? But osteomyelitis is an active, evolving infection. The big giveaways here are constant pain that gets significantly worse with movement, a fever, just a general feeling of being unwell, and, this is a big one, a complete refusal by the child to bear weight or even use that extremity. If a kid is running a fever and absolutely refuses to use their arm or leg, and there's no clear history of them taking a bad fall, that should immediately raise your suspicion for a bone infection.
Moving on to Section 2, Diagnosing and Treating Osteomyelitis. Now that we know what to look for, how do we confirm it and treat it?
To actually nail down the diagnosis, providers start with blood cultures to check for systemic spread, and they'll use an MRI or a bone scan to get a really detailed look at what's happening inside the bone. But the absolute crucial step here, the smoking gun, if you will, is the bone biopsy. The biopsy is what allows providers to pinpoint the specific organism causing the infection. Once they know exactly which bacteria they're dealing with, they can target their antibiotic therapy precisely.
Once that organism is identified, buckle up because the treatment course is unusually long and intense. We're talking starting with IV antibiotics and eventually stepping down to an extended round of oral antibiotics. This long duration is absolutely critical to stop the infection from turning into a lifelong chronic issue. But because we're pumping so many antibiotics into the body, the monitoring has to be incredibly strict. Providers are constantly checking the child's hepatic, renal, and hematologic functions to make sure their organs are handling the meds okay. They also have to watch like hawks for ototoxicity, which is literally hearing loss linked to certain antibiotics, and superinfections like C. diff or candidiasis, which happen when those prolonged antibiotics wipe out all the body's good, normal bacteria.
Okay, Section 3, Pediatric Amputation Causes. Let's wipe the whiteboard clean for a second and shift gears from infectious diseases over to the surgical realities of pediatric limb loss. When it comes down to it, pediatric amputation basically falls into three distinct clinical pathways. First, congenital amputations. These are planned surgical revisions for limb differences that a child is actually born with. Next, surgical amputations. These are also planned, but they're done as a last resort treatment for a severe disease. Think things like necrosis or a totally uncontrolled infection. And finally, traumatic amputations. These are sudden, severe emergencies resulting from an injury. As you can imagine, the clinical urgency and the amount of time you have to prep a patient are vastly different between a planned surgery and a sudden, chaotic trauma.
That brings us perfectly to Section 4, Emergency versus Planned Amputations. Let's zero in on that traumatic pathway.
In the high-stakes environment of a traumatic amputation, there is one absolute, unyielding guiding principle: life over limb. Period. Stabilizing the child's life will always take absolute priority over any effort to save the amputated part.
So the priority sequence in trauma happens in three very specific steps. Step 1, stabilize the ABCs: airway, breathing, and circulation. Because frankly, you literally cannot save a limb if the patient doesn't survive the initial injury. Step 2 is stopping the bleed and managing shock, using direct pressure or a tourniquet. It's only after the airway and shock management are completely locked down that the trauma team even looks at Step 3, which is preserving the amputated tissue.
Now, regarding that amputated tissue, there is a massive safety alert here. Proper preservation completely dictates viability.
You clean the amputated part with saline or water, but you do not, under any circumstances, let it have direct contact with ice. No way. Direct ice contact causes severe tissue damage. If you handle it improperly, you can completely ruin any chance of a surgical reattachment, even if the child's overall condition is perfectly stable.
All right, moving to Section 5, Phantom Pain and Bone Growth. We're shifting to post-operative care now, and we really need to clear up some major misconceptions.
First up, let's talk about phantom limb pain. We have to be crystal clear about this. It is a painful, genuine, physiological sensation. The child experiences it exactly as though the pain is coming from the missing limb. It is incredibly important to validate this. This is a real, physical reality that requires actual medication and pharmacological management. We have to firmly separate this from the idea that it's just psychological distress or, imagined pain. When a kid says they have phantom limb pain, they're experiencing something entirely genuine.
So that leads us right into a really specific, overarching question. Why is pediatric amputation fundamentally different from adult care? What's the major differentiator here? The answer is bone overgrowth, which you'll sometimes hear called bone spiking. Think about it. A child's growth plates are still wide open and active. Their skeleton is actively growing, so the residual bone can literally outgrow the surrounding soft tissue of the stump, pushing right into it like a tent pole. This creates a severe risk for skin ulceration. Because of this, a pediatric amputation is rarely just a one-and-done surgery. It requires constant monitoring and often extra surgical revisions like stump capping, just to protect the child's soft tissue from their own growing bones. It's a wild medical reality that totally changes the timeline of care.
Finally, Section 6, Prosthetics and Support. Let's look at the long-term journey of shaping, mobility, and mental health.
Long before a prosthetist even enters the room, the nursing team is already starting what's called residual limb shaping. They use elastic wrapping early on, and while yes, this controls postoperative swelling, it's actually doing a lot more. They are literally shaping the stump into a specific form to ensure that a future prosthetic will fit properly. If you don't control that swelling, you end up with an irregularly shaped limb, which totally delays the eventual prosthetic fitting phase.
And that long-term care journey? It is intense. Because the kid is growing, you have to expect frequent fitting appointments for the prosthetic. It doesn't mean something went wrong, it just means the kid got bigger. But beyond the physical, we have to place a huge emphasis on monitoring psychosocial distress, grief, and body image. Providers lean heavily on therapeutic play and distraction to help kids cope. Plus, physical and occupational therapy are heavily involved to make absolutely sure the child keeps hitting their developmental milestones regardless of the amputation.
So, I'll leave you with this final thought to wrap up our explainer today. How does treating a body that is actively growing fundamentally rewrite the blueprint for long-term medical care? A child's continuous growth makes their journey with bone infections, healing, and amputations a completely unique, constantly evolving challenge. It requires nonstop reassessment and incredibly specialized care. Thank you so much for joining me to map all this out today. Keep asking questions and keep exploring.